symposium, I would say. It's a pleasure and honor to have such an eminent doctor for this evening from the field of diabetes, medicine, and cardiology. So, without taking any further time, I would like to introduce and invite our moderator for the evening, and such a very renowned and eminent name from the field of diabetes and thyroid. Dr. S K Mathur sir. Dr. S K Mathur sir is currently designated as a senior consultant physician, Thyroid Clinic, Moderator, New Delhi. Sir is having a lot of major achievements, but note it down only two. Like he is an active member of Indian Medical Association. He is a life member of Association of Physicians of India, and he is also a fellowship American College of Pathology. Dr. Mathur sir, thank you so much for accepting to be a part of this meeting as a moderator. So over to you further today and invite our eminent speaker for the evening.
Thank you, Amit. Thank you very much. Good evening, everybody. And here is Dr. Viveka Kumar. And I think we really say Dr. Viveka Kumar is one of us. And Dr. Kumar is International Cardiologist, Principal Director and Chief Cath Lab Cardiology, Cardiac Sciences, and Max Super Specialist Hospital. Dr. Viveka has an extensive experience in the field of cardiac intervention and electrophysiology, done more than 7,500 angioplasty, 2,500 balloon valvulotomy, and with a very good outcome. He is a member of TAVI and a Structural Heart Fellowship on USA, Europe, and Denmark. Sir is MHRS member of the Heart Rhythm Society, and he has got many awards in studies like Chikitsa Ratan Award, DMA, Vidya Ratan Award, Contribution, and International Award of Excellence of Cardiology. More than that, Dr. Viveka Kumar has been an excellent teacher and excellent, I would say, physician, intervention cardiologist, and a great human being. He has been always available to us whenever we need his help. So I over to Dr. Viveka. Before that, should we introduce Dr. Chauhan? We go with Dr. Viveka. Yeah. Now, to introduce Dr. Chauhan, I think we are short of words. He is the leading man in the field of Physician Forum of India, and then the diabetes is the one second. Dr. Chauhan is senior consultant physician, diabetes and heart specialist at Chauhan Polyclinic, Viveka. Dr. Chauhan previously affiliated with the medical officer in the cardiology department at Safdarjung Hospital, New Delhi. Consultant physician at the EL Monshir Hospital, Al Joab, Sakaya, in Kingdom of Saudi Arabia. Consultant cardiologist in charge coronary unit at Shriram Heart Institute and Research Center, Kirtinagar. And he is MBBS, MD, Central Medicine from Maulana Medical, certificate course from the PHFI in diabetes, and certificate course from the Professor M. Vishwanathan Research Center. These are small introduction for him. Besides that, Dr. Chauhan is a great physician and a teacher. He has been working with the Physician Forum of India, rather carrying forward physician India up to the great height, and this involvement of his carrying on the CME after CME and every Wednesday number, of course, is not to be counted, they're carrying on. So I request Dr. Chauhan to be on the board and give his so-called the deliberation today to learn about fixed dose combination in the Empa and Lina, which are the drug of choice nowadays in treating diabetes, to prevent any, rather to start early, to prevent any complication later on in diabetes mellitus. So over to Dr. Viveka sir, your talk first.
Okay, so good evening friends. Thank you very much for this opportunity, and special thanks to BI for inviting me. So it's always been pleasure, and as Dr. Mathur said that I am a citizen of PFI. So if I say that today we are going to discuss about legacy meet on evidence-based optimization of Empagliflozin fixed dose combination in patients with type 2 diabetes. So I think if you see the cardiac perspective, we capture outcome data that showed that 34%, nearly 34% prevalence of CVD in general and type 2 diabetic patients. And if you look at the type 2 diabetic patient with no cardiovascular risk factor, the patients were almost 63.5%, and then almost one-fifth patient of type 2 diabetes with CVD use diabetic medication with proven CV benefit, meaning thereby that only one-fifth of the patients would benefit from the evidence-based beneficial drug which decreases the cardiovascular mortality in diabetic patients. And it's very, very important because more than 60% of diabetics would die because of the cardiovascular complications. So uncontrolled diabetes can lead to both cardiovascular and renal damage. You can see the end organ, the symptomatic systemic factors, diabetes, obesity, metabolic syndrome, hypertension and amyloidosis. These all lead to sympathetic neurohormonal activation. Inflammation is the crux of all these problems. Endothelial dysfunction, fibrosis, oxidative stress, and this end of the day leads to organ damage and dysfunction. So cardiorenal are the most important, organs which get affected because of the diabetes. So we need to see that the type 2 diabetes is a syndrome of cardiorenal mobility. And if you see the burden of cardiorenal metabolic condition in adults with type 2 diabetes, within the diabetic collaborative registry, you can see that, almost, 23% would have 3 comorbidities and 10%, 14% would have 1 comorbidity. Only diabetes is very minuscule. You can imagine only 6.4% of people have only, diabetes alone, and 27% have 2 comorbidities. So meaning thereby that multiple comorbidities is very common, ranging from 1 comorbidity to almost 5 comorbidities, and that is the reason why, and most of the prevalent individual conditions in the data of this more than 530,000 patients, there was hypertension, dyslipidemia, coronary artery disease, and CKD. And you can imagine that the concomitant hypertension was almost in 83% of the population, and CAD was again very high, 31% of the population. So is there an opportunity to address the issue of hyperglycemia, weight, blood pressure, albuminuria, and appropriate agent which can work on all these parameters? So we need to look at the case-based example. So this is a case who was a common garden variety of cases which all of us would be seeing. You can see that this bank employee, 55-year-old gentleman, had uncontrolled diabetes type 2 with symptoms of breathlessness. Past history was that he was diagnosed to have diabetes 6 years back on metformin monotherapy. There was no history of cardiovascular disease. Switched to sitagliptin metformin fixed combination twice a day 6 months back when HbA1c was 8.3 and HbA1c was 7.8. And again, the current medication was, sitagliptin, metformin, amlodipine, telmisartan, and rosuvastatin. So you can imagine that he was on medications where the blood sugar was not really well controlled. BMI was slightly on the higher side. In this situation, if you look at the further investigation, that clearly showed that there was, left ventricular hypertrophy on ECG with T-wave inversion. So there was deep S-wave in septal lead, and changes of endocardial strain pattern, ST depression, T-wave inversion was there. And this is a classical picture of left atrial enlargement, left ventricular hypertrophy, and ejection fraction was though normal but had some amount of diastolic dysfunction. Ejection fraction was 60%. So here, where do we go from this? So we need to see that, SGLT2 inhibitor plus DPP4, SGLT2 inhibitor first and then DPP4 inhibitor, or early initiation of this combination, because this is a patient where, the amlodipine, telmisartan, fixed dose combination was there, rosuvastatin, rightly so, but with this, the uncontrolled diabetes and symptoms of breathlessness. So this is a patient who was at a high risk of cardiovascular, involvement. The cost of delayed intensification is quite big. So if you see, retrospective cohort study of more than 5,000 patients from 1990 to up to 2012, HbA1c, 8.1 to 11, had history of cardiovascular disease, and newly diagnosed type 2 diabetes, 22% remained under poor glycemic control over 2 years, and 6% never received this. So what happens to these group of patients? And this again, it's a very large data that shows that there is a 67% increased risk of myocardial infarction, 1 year delay in receiving the intensive treatment. There is a 51% increased risk of stroke if you delay the intensive treatment, early initiation of intensive treatment. There is increased risk of heart failure by 64%, and again, cardiovascular endpoints increased by 62% if you delay. So therapeutic determinants for most suitable agents, and if you see the options as far as the oral agents and injectables are there, we have metformin, sulfonylurea, thiazolidine, DPP-4 inhibitor, SGLT2 inhibitor, and GLP-1 analog. So if you see the efficacy of HbA1c lowering, the obviously the SGLT2 inhibitor and DPP-4 inhibitor has moderate, but GLP-1 receptors and the insulin has got the highest ability in this direction. But the risk of hypoglycemia is an important thing as far as the cardiovascular adverse events are concerned. And there the safety is more strong with SGLT2 inhibitor, GLP-1 receptor analog, DPP-4 inhibitor, and metformin. So that's why these are the agents which are more preferred in our practice. And effect on body weight is also very important because, if you decrease the body weight, the need for anti-diabetic agents in itself goes down. So that's again very important. And the top among them is SGLT2 inhibitor, GLP-1 receptor analog, and also metformin. The safety and tolerability is best. If you can see the DPP-4 inhibitor is quite high, and cost of the therapy again with the understandably metformin is the drug which is very attractive as far as that endpoint is concerned. And then obviously the sulfonylureas are also cost effective. But when we look at the CV benefit effect, the SGLT2 inhibitor and GLP-1 receptor analog, they are very high in that. So therapeutic determinants for most suitable agents, if we see, then obviously the green boxes in this chart has to be picked, and cost for therapy or value for therapy will be something which is very important in this. So we need to have optimization with the early use of empagliflozin plus linagliptin fixed dose combination. And if you see this data that empalina combination, the efficacy here, you could see that almost HbA1c reduction in 24 weeks was on an average 1.2%, and you can see on metformin this was lesser, and proportion of subjects attaining the glycemic control was more than 60%, and duration of this trial was 52 weeks. Again, the other thing which was important was reduction in weight, blood pressure, and serum uric acid level. Over 52 weeks, you can see body weight reduction, BP reduction, and serum uric acid reduction was significantly prominent. And the choice of endpoints in CVOT outcome data, again, we have got lot of data from trials with each two components of the fixed dose molecules. Empiric outcome data, three-phase MACE reduction is very, very important. And Carmelina trial with the linagliptin also had shown its safety and efficacy in not only cardiovascular but renal outcome also. The quality of results in CVT OT outcome data also, linagliptin showed the proven CV and renal safety with potential benefit also with linagliptin, and empiric data which clearly creates a block flutter that really showed 14% relative risk reduction in CP MACE, 38% relative risk reduction in cardiovascular death, 32% relative risk reduction in all-cause mortality, and 35% relative risk reduction in heart failure reduction as well. So essential elements to be considered while choosing empalina fixed dose combination is the cardiovascular benefit and the renal benefit which need to see. So no dose modification is required in hepatic impairment with both empagliflozin and linagliptin. Renal evidence, cardiovascular evidence, and hepatic evidence is also there that in patient with type 2 diabetes, NFLD, empagliflozin significantly reduces the liver fat and improves the ALT level. So that is E-LIFT study that clearly shows. And also the stress-free uses, because we are not stressed out for hypoglycemia, for renal dose modification, and cardiovascular safety when we use this fixed dose combination. So essential elements to be considered while using this molecule is that we need to see the stress-free uses, that the side effects are minimal whatsoever, and then ease of use, that convenience of small tablet once a day pill with minimum monitoring, so we don't have to really monitor anything, and it is like even if the renal dysfunction is there, hepatic dysfunction, and if the patient needs cardiovascular benefit also, this combination works for all. If you look at the evolving evidence of empagliflozin benefit effects on the remodeling also, this was the EMPA heart study that clearly showed the left ventricular mass index reduction. So that has not been proven with any other anti-diabetic agents, and that is something which is really, quite impressive that the mass, LV mass reduction is there, and as we would know, it translates into the adverse cardiovascular event reduction as well. And both empagliflozin and linagliptin are recommended for type 2 diabetes management of patients with CV disease at the risk of the heart failure hospitalization respectively. It reduces the, so that is why the guideline, if you see 2019 ESC guideline, the SGLT2 recommended to reduce the cardiovascular risk, and that has been asked that, to be given as, first line drug in patients who have got high risk of atherosclerotic cardiovascular disease. So renal evidence, again, there is empiric renal outcome. There is almost 39% relative risk reduction of the incidence of worsening nephropathy in type 2 diabetic patient with cardiovascular disease. Carmelina did show 14% relative risk reduction to albuminuria in type 2 patients. And hepatic evidence also did show, ELI study, that there was no dose modification required in hepatic impairment with both empagliflozin and linagliptin. So randomized control trial evidence, both SGLT2 inhibitor with DPP4 fixed dose combination. The other one which we have got available is, DAPA with saxagliptin, and then empagliflozin and remogliflozin with vildagliptin. You can see that in all these, the right boxes ticked is most common with the, linagliptin and empagliflozin. If you look at the major beneficial points like CP MACE, cardiovascular death, heart failure hospitalization reduction, renal outcome data, and hepatic data also, and dosing convenience also on once a day. So this is the combination which is best suited in our patients in that way. So metabolic cardiorenal continuum, really the common soil for risk factors are the diabetes, hypertension, and obesity. So, if you see that if progressive micro and macrovascular complications happen and end-stage disease to the death can happen, so we need to, stop this trend. And if we don't intensify early enough, the patient would progress along the continuum, deadly continuum, I would say, and this would add to, early onset of micro and macrovascular complication, end-stage disease and health, and resulting into poor quality of life and increased cost of therapy also. So does it impact cost effectiveness of empalina fixed dose combination in long-term management of type 2 diabetes? I would say yes, it does improve. So if you look at this is a very elegant cost calculation, cost of diabetes in India. Diabetes related treatment will consume almost 28.3% of cost, and then treatment of complications and hospitalization 23.7%, monitoring and screening for complications 36%, and other costs will be 8.7%. So these are the direct medical costs, and indirect of unemployment loss or loss of, employed days would be 4.3%. But if you look at the potential impact of empagliflozin, it decreases the cost. Fixed dose combination is lower than the individual agent, so patient will get straight away benefit of 25 to 30 rupees. Then there is again 38% relative risk reduction in cardiovascular death, and significant reduction in hospitalization due to the heart failure. So the hospital bill will also become less. Patient will not need to be admitted, and relative risk reduction of heart failure hospitalization is almost 35%. And then 14% relative risk reduction in albuminuria with linagliptin, and 1.8% HbA1c reduction. So there is a robust glycemic control and minimal risk of hypoglycemia. So there are a lot of pleiotropic benefits beyond the glycemic control, and probably that's the reason why this agent, combination agent, would be very, very cost effective as well. So if we come back to our case, we can say that the optimal addition of empalina fixed dose combination in a 55-year-old male, you can see after 3 months, the HbA1c came down to 6.9. Weight reduction was also there from, baseline 84 kilograms to 78.5 kilograms. So there is an advantage of reduction in HbA1c level, reduction in weight, and there is a assurance of possible evidence-based CV and renal benefit also in these patients. I think that sums up that why should we be choosing this molecule for giving our patients cardiorenal benefit and overall decreasing the major adverse cardiovascular endpoints. So thank you very much for your kind attention. Over to Dr. Chauhan for this talk.
Thank you, sir. Chauhan sir, explain before, then we summarize the end. Dr. Chauhan. Dr. Chauhan, are you there?
Yes, sir, I am there. I'm just coming, sir.
Okay, go ahead, sir. Thank you, sir.
अभी पता नहीं, कल पता नहीं. हाँ, कोई बात नहीं, कल उठा लेगा. ठीक.
Can you see my slide, sir?
Yeah, we can see slide.
Okay. Can you see the slides? Can I start now?
Yeah, we can see the slides.
All right. Thank you, Dr. Viveka sir, and thank you everyone who have logged in. And as always, I am always helped by my wife with the technological issues. And we have 38 participants, and I hope that we will have at least 30 by the time I finish. Dr. Viveka being the showstopper. Actually, I am being asked to be the showstopper inadvertently. So thank you very much for your patience. Dr. Viveka sir has beautifully explained the usefulness of the combination of EMPA and DPP4, in this case linagliptin, and all the advantages that accrue because of this combination. He showed a lot of evidence and summed up with the beautiful slide of the cost versus benefit ratio. This slide I have shown often, and it summarizes the natural history of type 2 diabetes. I'll take a second to explain to this so that you revise your diabetes. As we happen from pre-diabetes to the diabetic phase, there is increased insulin resistance to begin with, and this increased insulin resistance then leads to elevated hepatic glucose output, ultimately resulting in beta cell exhaustion, decreased insulin levels and loss of beta cell function, increased insulin resistance and elevated hepatic glucose production in the pre-diabetic phase results in impaired fasting glucose, ultimately becoming frank diabetes. And when there is hypoinsulinemia or relative hypoinsulinemia, beta cell exhaustion, then ultimately resulting in postprandial blood sugars elevation. It is pertinent to mention that diabetes at the time of diagnosis is associated with a 50 to 80% reduction in beta cell function. So that is very important. So when we diagnose type 2 diabetic, nearly 80% of the beta cell function is gone by that time. And this is the famous trial, the UKPDS, one of the most beautifully constructed trials on diabetes. From 1977 to 1997, the supervised phase, and from 1997 to 2007, the unsupervised phase. And what came out of this was this famous and popular legacy effect, and it was that once the difference in the HbA1c was lost, after the first year, the patients in the intensive arm still had lower incidence of complications. And those complications were 24% relative risk reduction in microvascular complications, 15% reduction in myocardial infarction, and 13% reduction in all-cause mortality. So obviously, the microvascular complications were predominantly better as compared to the macrovascular complications, and this was between the conventional and the metformin or the intensive arm. And this continued to show results even after the patients were allocated to their usual physicians, and this close supervision was lost, and it showed that people who had initially good control over their type 2 diabetes continued to show better results whether on microvascular front or on macrovascular front. So the major factors at diagnosis influencing diabetes progression were higher HbA1c, younger age, higher BMI, lower HDL concentration, and increased TG. I must mention that lower HDL cholesterol concentration is almost a surrogate marker of very high insulin resistance and therefore elevated hepatic glucose output. So HbA1c at diagnosis is one of the main determinants of diabetes progression. Every 1% increase in HbA1c increases beta cell stress by 3.8%. On the contrary, every 1% reduction in HbA1c, there is a reduced risk of macrovascular complications like myocardial infarction and heart failure to the tune of 14-16%. Microvascular complications again outperform the macrovascular complications, huge benefit of 37%, and death decreases by 21%. So we have a prototype patient here, just for our benefit, presenting complaints, 49 years old. Sir presented a beautiful case, and I have another case to present to you people. 49 years, male patient, type 2 diabetic since 2 years, so early in the disease, history of hypertension and dyslipidemia as comorbidities, blood pressure 130 to 82, and BMI of 28.5 kilogram per square. So he is obese. He was put on metformin 500 milligram twice a day, initiated after 3 months of lifestyle management, not worked. Therefore, the dose increased to 1000 milligram BD 6 months back when the HbA1c was 8.3%, still not optimum control, but he is on now optimum doses of metformin. Currently, this patient is on metformin 1000 milligram twice a day. He is on a combination of amlodipine telmisartan 5/40 once a day, and kindly read rosuvastatin as 20 milligram once a day, not twice a day. His current lab parameters are his HbA1c is 8.6, his fasting plasma glucose is 165, not ideal. His PPG is also not ideal at 280. His LDL cholesterol is not ideal at 120, but his eGFR looks to be fine at 73. So, what are our primary clinical concerns for our reference case? Case of this 49-year-old male, uncontrolled glycemia, HbA1c of 8.6, he is obese, and additional risk factor of hypertension. Now, we don't have a poll here, but we can have an opinion here. So, either we add a single, he is already on optimum dose of metformin, we could either add DPP-4 inhibitor or a sulfonylurea to the optimum dose of metformin, or we could initiate a combination of SGLT2 DPP-4 inhibitor, fixed dose combination along with metformin, or we might have any other combination that we might have in mind. Remember, none of the choices that we make will be wrong, but what will be the most correct choice, that we have to really understand. So that brings us to the statement of ADA 2021, and that tells us that absolute effectiveness of most oral medications used in monotherapy rarely exceeds 1%. So our patient is at 8.6%. He is 1.6% above the target. So what are the various agencies saying? So ADA 2021 tells us initial combination therapy in patients presenting with an HbA1c levels of 1.5 to 2% above the target, initiate a combination therapy. Similarly, by ACE and ACE, almost the same thing. An entry HbA1c of 7.5 to 9%, which is actually 1.5 to 2% above the target, recommended by ADA of 7%, consider dual or triple therapy. And our own agencies, RSSDI, Endocrine Society of India, 2020 recommendations tell us, consider initiating combination therapy if the HbA1c is 1.5% above the target. So we have these three recommendations, and what are the molecules that we have? So our patient, reference patient, is already on metformin optimal doses, and we have choices to make. Either we put the patient on SGLT2 alone, DPP-4 alone, along with metformin, or we can put him on sulfonylurea. And which of these molecules are ticking most of the boxes when it comes to glycemia control, hypoglycemia, weight loss, and decrease in blood pressure? SGLT2 inhibitors are ticking most of the boxes. DPP-4 inhibitors are neutral on weight loss and blood pressure, but are ticking glycemia control and hypoglycemia. None of the other molecules which our patient is already on metformin tick these boxes, and sulfonylurea is a very, very poor force. So what about the possible effects of combination, fixed dose combination of SGLT2 inhibitors and DPP4 inhibitors? Weight and blood pressure reduction, powerful and early efficacy, low risk of hypoglycemia, cardiovascular and renal benefit, safety, evidence of individual components. These are our priorities. So powerful and early efficacy, definitely, even to the tune of more than 1.5%. What about low risk of hypoglycemia? You know from our experience and data that we have, SGLT2 inhibitors do not cause hypoglycemia, whether used in combination or used in monotherapy. Similarly, DPP4, large data now, robust evidence, no evidence of hypoglycemia. So what about weight and BP reduction? Yes, we have very encouraging data with SGLT2 inhibitors, and we know DPP4 inhibitors are neutral on weight. What about cardiovascular renal benefit safety data? We have an ample of it from Empagliflozin. We have renal benefits from Carmelina, and we have the exploratory endpoint data on Empagliflozin, on Empagliflozin about renal benefits. So we have all these benefits with this combination. You know, friends, that from the classical triad, the ominous triad of elevated hepatic glucose production in the liver because of elevated insulin resistance, decreased insulin secretion because of beta cell exhaustion, and decreased peripheral glucose utilization, mostly at the level of the muscle. De Fronzo propagated this very famous theory of ominous octet, and I will not go into the detail of this because most of you know it. What is my relevance here is that when you use this combination of SGLT and DPP4 inhibitors, all of this ominous octet are being addressed to by the combination of metformin, on top of that by a fixed dose combination of SGLT2 and DPP4 inhibitors. Not going into the details, just for the benefit of time, and Dr. Viveka sir has beautifully explained the other things. So what are the key takeaways in the fixed dose combination group? So significantly higher rate of adherence therapy, that is the greatest advantage of using the fixed dose. We have more compliance, 28% higher odds of adherence, and we have significantly lower rate of non-persistence. So people who will leave out treatment, who will leave out individual components of treatment because of increased and elevated cost of therapy, 21% lower odds of non-persistence. So differences from a cost perspective too. Results favored fixed dose therapy, including total predicted monthly all-cause cost and type 2 diabetes related costs as compared to loose drug combination therapy if you were to use them individually. That brings us to our second opinion. We don't have an opinion poll, but we have an opinion here. This 49-year-old, uncontrolled glycemia, obesity, additional risk factor, whether we should use sequentially SGLT2 or DPP4 on top of metformin, or we can start early the combination of SGLT and DPP4. Does it offer additional glycemia benefits? Does the approach address pathophysiology better? Would it improve unmet clinical needs such as weight gain, hypoglycemia? Would adherence compliance improve and also improve the clinical inertia? So compelling reasons to initiate Empagliflozin Linagliptin fixed dose combination as next line therapy in patients with type 2 diabetes inadequately controlled on metformin. So what is the evidence that we have? So our reference patient has uncontrolled glycemia, 1.6% above the desired level as advocated by ESD, ADA, etc. So we have two scenarios here, low baseline HbA1c and high baseline HbA1c. And most of the agencies are recommending that if we use these drugs in monotherapy, they do not decrease HbA1c by more than 1%. But whether we are dealing with low baseline HbA1c like of 7.9 or high baseline HbA1c of 9, the HbA1c reduction is to the tune of nearly 1.2 with combinations of EMPA and Lina. On high baseline HbA1c, as you would remember from your earlier teachings, higher the baseline HbA1c, more is the HbA1c reduction. EMPA and Lina combination gives higher HbA1c reductions as compared to monotherapy. What about using them in drug naive and on top of metformin. Our reference patient is already on metformin. So what about drug naive patients? Yes, the combination works as good as well as in patients on metformin background. There is an early and robust decrease in HbA1c reduction, whether our patients are drug naive or our patients are already using metformin. So our primary goal is to achieve more and more percentage of people who can reach their target HbA1c, and a target HbA1c being 7%. So in drug naive patients, there is a 2 to 4 times more likely chance of attaining target HbA1c than monotherapy. Even in patients who are already on metformin, the chances are even right up 3 to 5 times more likely to attain target HbA1c as compared to monotherapy. Now, apart from this, there are other additional benefits. You know, diabetes never comes alone. It comes with comorbidities. Obesity, our reference patient is having obesity. He is also having an additional risk factor of hypertension. So body weight reduction with the combination is better as compared to monotherapy. Serum uric acid, which is also a very important part and parcel of the metabolic syndrome, is also being influenced beneficially with the combination. Now, we have to understand with what cost we are getting these benefits. So despite high efficacy, there is no increased risk of hypoglycemia with EMPA plus linagliptin. You would remember, sulfonylurea is one of the options that we considered, but please understand there is a nearly 90% more chances of hypoglycemia achieving these targets with sulfonylureas as compared to this combination. So the cost that we have to pay to achieve our HbA1c targets and even weight targets and other metabolic targets are much less when we are using this combination. Lower incidence of genital tract infections with EMPA plus lina. You know, friends, that empagliflozin, SGLT2 inhibitors in general, we know that there is an increased risk of genital tract infections. But when you are using EMPA and lina in combination, there is a decreased risk as compared to monotherapy, whether EMPA 25 or EMPA 10. And one of the hypotheses which has been propagated is that most of the fungi, that afflict the genital tract, they have DPP4 receptors expressed on them. And when you are using a combination, and if you inhibit those receptors on the fungi, then there is a decreased risk of catching the infection. Just a hypothesis, but a good enough hypothesis to explain that when used in combination, the chances and the prevalence of genital tract infections is much less. So EMPA plus lina FDC affords early and robust HbA1c reduction of 1.8% from mean baseline of 8.5%, significant weight and systolic blood pressure reduction, minimal risk of hypoglycemia, and lower risk of genital tract infection. But is this enough? So that brings us to the next question. So what are the essential elements of choosing an empagliflozin linagliptin fixed dose combination? Strength of evidence, safety as to CV, heart failure, renal hepatic safety, stress-free usage, which Dr. Viveka has beautifully explained already, and any other option. So strength of evidence, friends, efficacy, we know already from EMPA, robust and early HbA1c reduction, weight and BP reduction. We have good enough studies over 52 weeks in 269 treatment naive and 269 type 2 diabetes, uncontrolled on metformin, and these are 4 real-world evidence studies conducted in our own country. We often say that the trials are conducted in West, they are meant for West, but these are real-world evidence, RWT, from India, conducted in 4 metros, Mumbai, Ahmedabad, Kolkata and Jammu, which have amply demonstrated that the efficacy and safety is good enough for this combination. What about the metabolic perspective? Robust HbA1c reduction of 1.8%, significant pleiotropic benefits like weight loss, BP and uric acid reduction, which I have already told. Dr. Viveka sir has beautifully summarized the CV perspective. The data from EMPA 3-point MACE down by 14%, CV death down by 38%, all-cause mortality huge benefit 32%, and hospitalization on heart failure benefits with EMPA 35%. This is, and also ample safety with lina. Lina perspective already demonstrated by STAR 39% relative risk reduction of incident or worsening nephropathy in type 2 diabetes patients with established CVD with EMPA exploratory endpoint, 14% relative risk reduction of progression to albuminuria in type 2 diabetes patients, Carmelina, both EMPA and Lina showing renal benefits and safety. Sir has already shown this slide. I won't spend much time. Just to mention that EMPA and Lina combination is ticking most of the boxes which are not being ticked either by DEPA or SEXA, a combination which is available outside India, not yet available in India, and Remo and Velda, not even very poor third. So our patient, our reference patient who is early in the disease, hypertension, diabetes, obesity, and we know that he will progress along the cardio-renal continuum based on atherosclerosis, LVH, he will get into macrovascular complications, myocardial infarction, heart failure, which will predate the microvascular complications of micro and macroalbuminuria, and then ultimately he will end into end-stage heart disease and cardio, cerebral vascular death. And our patient features in the early phase of metabolic cardio-renal continuum gives us enough time to intervene. If not intensified early enough, he would progress along the continuum. You would all agree. This would add to early onset of micro and macrovascular complications, end-stage disease and death, resulting in poor quality of life and increased cost of therapy. So what about the use of EMPA and Lina FDC combination early in this patient? Robust up to 1.8%. I think the 7th time I am saying HbA1c reduction in patients uncontrolled on metformin, significant pleiotropic benefits including weight and BP reduction, also uric acid reduction, MACE and heart failure benefits as amply demonstrated by EMPA-REG, and safety with Lina as demonstrated by Carmelina, albuminuria benefits with Linagliptin both with micro and macroalbuminuria, and CV death risk reduction patients with ASCVD and type 2 for the first time in the entire history of any anti-diabetic treatment, all the trials. So for so many years, for the first time, we have seen a molecule impacting the cardiovascular death so beautifully and so beneficially, which no molecule has done. Even insulin could not do it in the best constructed trial of UKPDS from 1977 to 1997. Renal safety established with Linagliptin in high-risk patients with Carmelina. And friends, the common soil of risk factors, remember hypertension, diabetes, obesity in our case, micro and macrovascular complications, robust HbA1c. This patient was uncontrolled on metformin. Therefore, we need a significant HbA1c reduction to achieve our targets. MACE and heart failure benefits with EMPA, outcome and safety with Linagliptin as I already demonstrated. CV death risk reduction in patients with ASCVD and type 2 diabetes. Does this impact cost effectiveness of EMPA, Lina, FDC in the long term? Dr. Viveka sir has beautifully explained this, and I'm not going to revise this. What I'm going to tell you is this. My emphasis will be that cost of FDC is lower than individual agents. Significant reduction in CV death EMPA with EMPA-REG outcome. And not only CV outcomes, you have 14% relative risk reduction in albuminuria benefits. And this albuminuria is not only microalbuminuria, but even macroalbuminuria. So a molecule which is impacting HbA1c, which is protecting your kidney, which is protecting your heart, which is protecting your patients from going into hospitals because of heart failure, impacting your overall mortality by 32% and CV mortality by 38%. What more do you need, friends? So where do you need early intensification with EMPA and Lina? Early before metformin? I think most of you would say no, metformin being cheaper and very effective, especially in a reference case where elevated hepatic glucose output is one thing. Metformin being the best medication to decrease hepatic glucose output by decreasing insulin resistance at the level of the liver, or early as a partner with metformin. I think most of you would now say that we would like to use it early as a partner with metformin. All right? And therefore, we are moving from a glucose-centric approach to a holistic approach for our patients, beautifully demonstrated by Dr. Viveka sir in his slides. I would just like to summarize that we have metabolic benefits with this combination, nearly 1.82% reduction on higher baselines, CV perspective, demonstrated beautifully by Dr. Viveka sir, 3 points: MACE reduced, CV death reduced, all-cause mortality and heart hospitalizations because of heart failure benefits with EMPA and safety with Lina, and even renal perspective, 39%, nearly 40% relative risk reduction of incidence or worsening nephropathy in type 2 diabetes with established CVD with EMPA, and this has come out from the exploratory endpoint analysis of the EMPA-REC data, and 14% relative risk reduction progression to albuminuria in type 2 diabetes from a glucocentric approach to a holistic approach. It's not only HbA1c reduction, it's also about protecting your heart, protecting your kidneys. So friends, I would like to thank you for your attention, and thank you for bearing with me for being very poor with technology. Want to thank my wife, Dr. Renu Chauhan, for helping me with this. 38% people are logged in, Dr. Viveka sir. 38 were logged in when you started. I have been able to hold the one end of the crease, sir. And thank you everyone for tuning in, and congratulations everyone for winning the oval test after 50 years. Thank you, sir. Dr. Mathur, sir, thanks a lot. Thank you, Dr. Viveka, sir. And thank you everyone for listening to me. And I feel this as a matter of prestige, privilege, and honor to honor the same platform as Dr. Viveka, sir.
Thank you, Sushil, for an excellent talk. I'd like to thank both of you. Dr. Viveka, of course, is the master speaker, as all we know. But the way you both highlighted the role of fixed-dose combination of EMPA-Lina in a treatment of diabetes mellitus as a pleomorphic effect later to prevent the later on complication of the cardiac and renal thing. I think that will be great, beneficial to people, will be benefited by the patient, and both the patients which both you highlighted. It will definitely a great education for all of us. And I would like to thank Dr. Viveka sir. It was a very nice talk, and so Sushil, great highlighting the whole thing. If there are any questions on chat box, you can Yami.
Sir, thank you so much, sir. We have received few compliments also in chat box. So I just would like to read out for you. Dr. Serene is saying that superb talk, and Dr. Sunil Kapoor is mentioned that it's a terrific talk. Congrats. So Dr. Sunil Kapoor is also asking what is the trade name. What does it mean, sir?
The trade name of the combination. He is asking about the trade name of combination. The trade of the combination. The trade name of the combination is called Glixambi. It's a combination of Empagliflozin and Linagliptin. It comes in two strengths. It comes in a combination of Linagliptin 5 mg, which is constant, and Empagliflozin, which comes either as 25 mg or 10 mg. Sir, you can use any of the combinations, whether you can, and it's a very effective combination. I've been using it ever since its launch, and I think Dr. Viveka sir would vouch for it. It's a very cost-effective kind of a combination. I have seen Dr. Viveka sir using Empagliflozin left, right, and center for all his patients. It is a cardiac medicine. It is an endocrinologist delight, and it is also a nephrologist delight. It is one drug, one combination, which can be used across the board. I think, sir, your comments, sir, Dr. Viveka sir.
Yes, I fully agree, and as we have highlighted in our talk also, that this is the drug of choice for cardiorenal adverse effect prevention. And in our group of patients where the diabetics who have got the cardiac issue plus those who have got mild renal issue also, this is the wonderful drug to have. And it is the safe drug. It is something where it is easy to use and also the most cost effective, because it will prevent hospitalization, it will prevent progression of renal disease, it is going to prevent the major cardiac endpoint, the MACE events. And so I think this is something which is really good, and no wonder that it is coming in such a big way that people are, and leading physicians like Dr. Chauhan and all, everybody is using it.
Dr. Viveka sir, we have one question in chat box. So if you allow, can I go ahead? Can I read it out for you, sir? Sir, first of all, Dr. Manish Gupta sir is saying that excellent presentation, chief. Sir, comment on HFpEF data with Empagliflozin. He's asking about it.
Yeah, so that's again very good point that, we did not have any other molecule except for MRA in FPEF. And so this is a molecule for heart failure. As you would know, the ARNI had come, but that did not reach the statistical significance of protection in HFpEF. But the empagliflozin, so empapreserve data, what we call emperor preserve data, so that really showed that the evidence is there. And so now all heart failure patients, be it diastolic heart failure, be it systolic heart failure, mid-range ejection fraction heart failure, in all these groups, this is a molecule which is working. So not only the hospitalization, but also the harder endpoints of mortality also decreases. So I think that's a very good data. So I would say, Dr. Manish, that we have got one molecule which will work in all these spectrum.
Sir, thank you, sir. Thank you so much for nicely answered the query. Dr. Chauhan, sir, you can take it up this question from Dr. Sunil Kapoor, sir. Sir, want to shift the patient on sulfonylurea plus metformin plus DP4 inhibitor. How to go about it?
I would like to know what is the HbA1c and why you are trying to shift the patient from sulfonylurea to other combinations. But I presume that you are wanting to shift the patient from sulfonylurea to other combinations probably because the HbA1c is not at target. So my recommendation to you would be do not stop the sulfonylurea completely. And if you want to start using SGLT2 inhibitors, reduce the dose of sulfonylurea by half and then gradually build up the dose of the other medications, whether it is metformin, and reduce the dose of sulfonylurea to completely to as low as possible, so that you do not have to face the consequences of hypoglycemia. Please understand, if you are using 4 molecules, sulfonylurea, metformin, DPP4 and an SGLT2 inhibitor, the chances of the patient going into hypoglycemia will be much more. Therefore, try and get rid of sulfonylurea as quickly as possible. But for beginning, reduce the dose of sulfonylurea to half and then go on increasing the other 3 components of the combination. You will achieve your targets.
Thank you so much, sir. Dr. Sunil Kapoor mentioned that it's a better combination and want to get rid of sulfonylurea. So, thank you, sir. Sir, any expert comment from your side of the S K Mathur, sir?
Yeah.
There is no question in chat box. You're
good. Once again, thank you, Dr. Viveka sir and Dr. Chauhan. What a lovely talk. Both of you highlighted the role of fixed dose combination of EMPA and LINA. And important point you highlighted how early we can start to prevent a legacy effect, as we talked about, of diabetes. Diabetes is a very common disorder which is in our practice, and it has got so many side effects or complications. Generally, as we say, diabetes doesn't come alone. It comes with the comorbidities like overweight, dyslipidemia, hypertension. So this particular drug has done a wonder in maintaining both the parts, or the controlling diabetes along with the other comorbidities. So it is a very well presented by Dr. Viveka and Sushil. Thank you very much for a very nice talk. The carry-home message is to start EMPA and LINA combination early in the management of diabetes to prevent the complication later on. Thank you so much once again.